He's hankering for some banana bread. So I think we've got, we're at about 24, 25 people. So I think we'll get started. We may have a few more people join us throughout the talk, but no worries there. So first of all, hello and welcome everyone. My name is Ida Fernandez and I'm the Executive Director for the Imagine Spore Network. Today's session, we're really looking forward to it. It's a next installment in our network's monthly training webinar series aimed at building capacity and improving the design of future research studies. So I'm really excited about today's talk. It's on mental health research on patients with IBD and IBS. But just a few housekeeping items before we get started. So please, first of all, if you can ensure to keep yourself on mute throughout the presentation so that we can minimize the background noise. And of course, that's happening as my phone is ringing in the background. So I apologize for that. There will be 15 minutes allotted at the end of today's webinar for some questions and answers. So we encourage you to type in your questions anytime throughout the presentation. You can use the chat box and you'll see the little icon at the bottom of your screen. And at the end of Dean's presentation, I'll read them out to our presenter and we'll be able to answer them that way. If, of course, we don't get to your questions, Dr. Tripp has offered to get back to you by email. And so we're going to do our best to make sure we answer all your questions. So please do enter them into the chat box. Following this meeting, you'll receive a link to complete an evaluation survey. So we really want your feedback so we can continue to improve these sessions. And also it allows us to track participation for those of you seeking CanMed credits. Finally, we do record these sessions. We archive them on our website for future viewing. So if you want, please visit imaginespore.com and share the link with your colleagues who weren't able to join us today. And you can also check out our previous training sessions there as well. So Dean, next slide. So who we are. So the Imagine Network is a network investigating the interactions between inflammation, microbiome, diet, and mental health in patients with IBD and IBS. Our mission is to transform the management of IBD and IBS and the associated mental health issues that are obviously associated with these disorders. So I'm just gonna, next slide, Dean. So before we hear from Dean, I just wanted to briefly introduce you to Dean and give you some background as to why we've selected him to present today. So Dr. Tripp is a full professor in the Department of Psychology, Anesthesiology, and Urology. He's the current chair of the Queen's General Research Ethics Board and is the high performance mental training coach for the Department of Athletics. He's published over 80 peer-reviewed publications and chapters, 5 treatment manuals, and has developed 14 CME credit pain education conferences in Kingston. Nationally and locally, he's been awarded for his excellence in teaching and research. And his primary research area is focused on pain and psychosocial factors associated with self-regulation across abdominal pelvic conditions. So I will now pass it over to Dean for today's talk.
Thank you very much. And I want to make sure that the slides are still working okay. Everything's going okay. I'm on my disclosure slide right now. Okay. Great. So you can see the disclosures I've listed there and different various roles. So, I mean, this is where I wanted to get to today, the beginning. I'm excited to be able to have this opportunity. Thank you very much for inviting me. And I'm looking forward to sharing sort of my insights, or at least what I think are important insights in regards to conducting this type of research with our populations of concern. So let's just jump right in. I want to get through the learning objectives first and get a sense of you know, where we're going to be going. I think I have a couple of learning objectives set up. And the first one really is just to get an appreciation of sort of some of the challenges or barriers that might be out there in conducting mental health research in IBD. Really trying to get an understanding of how, you know, to use theory that exists out there. And I think this is very important for me, is to try to tie, you know, practical information we get from our patients to theory. So I think there's that connection between, you know, those two things that help us design quality research, at least from my perspective. And finally, I will take some time to talk about common survey instruments that I use that can be used in mental health studies. I'm going to be biased, of course, in presenting some of the stuff that I think is kind of cool and ties in with the theory-based work that we like to try to accomplish. Again, at the end, we'll have Q&A, so hopefully we have time for that. If we run a little short, like I just said, I'm happy to respond, to you guys by email, and we'll work that out. My layout for today, in looking at these objectives, was to show you what my lab and I have been up to, and talk about the perspective of these objectives from in some of the research that we're doing. So we get a chance to kind of look at some of the work that we've been involved with. I picked 3 studies out of like 5 that I thought would be reasonable. So I picked 3 out of 5, and I hope you enjoy them. So let's get into what I want to speak about now. This is a really cool term, psychogastroenterology. And I remember thinking about this because people will often ask me, like, what is the role of a psychologist in IBD, or what is the role of the mental health provider in IBD, psychiatry, psychologist, social worker, mental health nurse, what have you. And I really think when we're talking about our group of patients, I want to make something clear that there's a lot of variability in our patient groups. And I think you know that. So in regards to psychological intervention, then, how can we treat such a diverse population? I mean, that's a key. I mean, when I first started doing some IBD work with Michael Bayak and Mark Ropoleski here in Kingston, and then getting to work with Steve Vanner, I really did get a sense of that kind of disparity or differences in our population. So, I mean, obviously some people can be, shuttered off to general psychologists. And I think those people in the population exist. And they're really, I would suggest, people with mild to moderate bowel symptoms. Quality of life is impacted, of course, but they're higher functioning status. And the reason I say general psychologist is because many people are just dealing with life adjustments and their illness isn't a primary focus. So sometimes the relationship stuff and stress is easily handled by a psychologist in the general practice sense. But again, sometimes we have to ramp that up. So if we think about, the green group here, what's going to come out of our population, and we think about that, it's more about a specialization now. So, there is this general psychology group that can be treated by general psychologists in the community. But then I think there's a specialization in health psychology in particular, where more severe bowel symptoms, surgeries, higher BSI scores, maybe lacking insight, very confused about their life situations, very hard on themselves, motivationally speaking. So they're getting to be, in a real sort of psychological place that is going to be a little tricky because of the disease management aspects. And then I think, so there's two clear separations. And then there's a third group down here, which is, and I'm going to talk about this today, one that might be active in suicidal ideation, could have more severe psychopathology, and that type of group as well could benefit from medication, psychiatric intervention, and a variety of other things. So, I mean, I just want to give you that overlay to kind of think about the project that I'm going to talk about and the way I see our population in terms of structuring care and mental health research in particular, because I like to think of those two things always together. So the first project I want to talk about is an examination of inflammatory bowel disease and quality of life. And in this study, I mean, obviously we know that abdominal pelvic pain is a huge symptom, and we know a lot of people suffer from this sort of experience without biological disease markers. And we know that there's significant impact on their quality of life. The question in this study was how, and really from my perspective, I want to know about the mechanisms that might help us explain the relationship that's obvious between pain or disease or later quality of life. And in looking at the literature, really there was no studies that have kind of mapped it out in that way, looking at quality of life down the road as with pain and a couple of other factors involved. So the objectives in this study were to kind of look at, using a longitudinal model, really examine pain, health, related quality of life, but also inserting anxious thinking about your pain, coping, and different types of factors that might help us explain what pushes that relationship to be more negative. So that's kind of how this project came about, and let's get into some of the results. So here's a picture, and of course this is from our group in Kingston, and the manuscript is in preparation, so you are seeing hot data, as they say. And when we think about this picture, really there's just a couple of important things to look at. This is time 1 pain, of course. This is time 2 assessment, looking at pain catastrophizing, which I'll talk about throughout today, and illness-focused coping, which I will also talk a little bit more about, and then health-related quality of life at time 3. So this sort of serial mediation, if we want to call it that, basically helps us examine what happens or what might be mechanisms of the relationship that push that relationship we see rather between higher pain creating lower health-related quality of life over time in our patients. So the data basically comes out to be fairly straightforward. I hope I don't have any fancy X's. No, I don't. Good. I just want to double check. But basically, we know that pain will create greater sort of anxiousness about pain. It will create this construct known as pain catastrophizing in our patients. And I like to refer to it as anxiety about pain. And when I talk about this measure a bit later, you'll see why. And then this factor influences or creates more illness-focused coping in our patients. And those types of coping strategies really look at sedentary behavior. These are behavioral pain coping factors. And they show us a variety of things that our patients are doing, but predominantly accepting a sort of sedentary and passive approach to trying to manage any pain that they have. So almost like a helplessness, if you can imagine that. And we know that in concert then, these variables over time tend to negatively impact the quality of life that our patients are reporting on. So this is one study when we think about some psychological factors and measurement, and I'm going to talk about these two measurements in a second, are important too, because they talk not only about the theory of how catastrophizing about one's pain fits into the relationship between it pushing bad quality of life, and also what other factors might spring out of the catastrophizing. And not a lot of people look at that. So I think it's important to try to contextualize these effects, and that's what we did in this study. So the takeaways for this research, I think, are pretty straightforward, that, when you have illness, and perceptions of your illness, they influence illness-focused coping. And this is followed by adjustment outcomes, and like I said, with health-related quality of life that we want to be cautious looking at. So higher pain predicts greater catastrophizing 3 months later, which in turn leads to maladaptive illness-focused coping, if we can refer to it as that, which then leads to attenuated health-related quality of life, as I said. The model suggests only the indirect serial mediation path in predicting future drops in quality of life for our patients from pain. So that's another side, a more statistical side. But basically, it's one of those things that we know that catastrophizing and illness-focused coping have a role. So these are, I'm not going to read through these, but I put these in the slides so that you could have these as references if you go back and look at it, or if you get a PDF of today. These are just the slides that were used. I say notes on the measures used in the study I just talked about. So the illness-focused coping, the health-related quality of life, pain, how it was assessed, the CPCI as well, which we used, and the pain catastrophizing scale. Just giving you a bit of information about those measures there for your reference later. I just thought I'd throw that in. The next study I want to focus on is an IBD group therapy study. We put our therapy together because we were looking at group approaches because we found them to be more successful in regards to resources. And a lot of patients, although they may be a bit worried about being engaged in the beginning, really benefit from these processes of being in groups and sharing. So we looked at lifestyle adjustments involving medical care, behavioral changes, and psychological functioning. And that's when we really start to want to focus in. The problem with a lot of the research that we found when we looked at group therapies in IBD or therapy in IBD, that it was relatively inconsistent. So we know that some studies have got some good data, some older studies not so much. And we know some current studies underway that are showing some positive outcomes as well. So it really was, how can we look at developing a psychotherapy for group process that could be run in hospital, could be run online. Now, obviously, we well aware of that. And we thought, from a theoretical perspective, let's use a CBT or a cognitive behavioral therapy or, sort of theoretical orientation in how we're going to approach the self-management. Let's make it self-management perspective. So it involves a lot of homework, not a lot of homework, but I always say a lot when I'm giving out homework. I'm sorry, it's a teacher of me, I guess. But, there's homework and there's engagement exercises, as I like to refer to them sometimes as well. So these types of things are what we wanted to add into this therapy in particular because it's effective and has a track record, as Leslie Graff will tell you. But the other thing I wanted to do was put a manualized protocol in place so that, if we see benefit from the therapy, we can not only change it or augment pieces to it or take a piece out that doesn't seem to be effective, but we can give this away. So if there is a hospital that wants to do, an empirically supported group psychotherapy, 8 sessions with their patients, run it this way, here's all the handouts, everything you need. This is what we wanted to do because we can test the modality. We're not ready to ship that out the door yet. There's some changes that need to be made. I think you'll see when I show you the data, but we're pretty happy with what we got on first blush. So that was the number one objective. And when we think about the therapy development, like I was hinting at, we used the cognitive behavioral self-management program concept. We took a lot of patient feedback on the program and doing it. We looked at different modified focus groups as well from professionals, psychologists, some patient groups as well, different age patients, and really used sort of this argument technique as the basic mechanism of therapy. So teaching patients how to understand how events can trigger emotions and feelings and beliefs that lead to consequences. So it's those beliefs and the way you perceive your world we really want to focus in on. So we're extending previous studies in a couple of ways from our perspective. So what happened? Well, we have some data. And again, this is kind of like a large sort of pilot group study, if you will. It's bigger than a pilot study, but it's not quite a randomized controlled trial in regards to the numbers. COVID cut us short, so we weren't able to get the ends we're looking at. But what you can see here is basically effects for catastrophizing anxiety and patient shame, all showing significant reductions down. There were a couple of other measures approaching significance, but I didn't want to talk about approaching. I just wanted to show you what kind of made the grade. And what's interesting about the changes in our program, you can see over the treatment group versus a control group, so treatment's blue, is that I'm really excited about 2 things: shame, anxiety, and the generalized catastrophizing measure. I want to just take a second to talk about catastrophizing because the first time we looked at it today, excuse me, it basically was pain catastrophizing. So specific to your pain. What we did was adapt the measure and sort of take out sort of the pain referent in parts of the question and left it more general in regards to life and managing life. And we found that pain catastrophizing did not quite change significantly, but it was starting to look like a trend. But generalized catastrophizing did change significantly in our group. And this is only over 8 weeks. I mean, this is very interesting to me because that drop is more than significant if you look at the value drop there. If we would think that a change in about 4 points on this would be reasonable to say that had some impact, that's a pretty significant drop. So we're very happy about that. And what it says to me is that a couple of things, and I'm going to mention them next in our takeaways, is that catastrophizing is not only about pain for our patients. And that concept of catastrophizing is getting beat around in the press a lot lately. So we can call it a feeling of helplessness and anxiety about one's life. We can call it a feeling of helplessness and anxiety about one's pain. To me, it doesn't matter. Well, it does matter what it is from a patient's perspective. From a science perspective, the construct stays the same. I want to make that clear. So basically, when we think of our takeaways in the study, the adjustment in areas that have not been included in previous IBD psychotherapy studies, like catastrophizing, social support, which we didn't see an effect for. We also looked at body image, stigmatization, and shame. So we have some effects in some of those areas. I want to keep working at those things. and say to therapists out there that these are important pieces of looking at how to change people's experience with their disease. I mentioned earlier, we have a lot of variables that came close, but I'm not into close. I want us to make sure they're pretty good, considering we're at the early stages of kind of, polishing this therapy up. Again, general CAT is basically something that's novel, not been looked at before in our group. So again, I encourage you, when you're thinking about mental health studies, to think about constructs beyond something like a pain catastrophizing. What is the construct features? Like, what are we trying to assess? And from my perspective, I'm trying to assess a sense of helplessness and a sense of anxiety about the stress they're experiencing in their lives and or the way they think it's all going to work out. So for me, with my IBD people that I've been engaged with in the world, I've seen that clearly. They've communicated clearly to me, and they've communicated to me in our science. So we're on to something here, and I'm going to follow this up in the years to come for sure. The last study I want to review with you, and I apologize if I'm going quick, but I don't want to be caught here all day on these, is the IBD Suicide Risk study. We just published this study in 2020, so it's fairly new for our lab, and I want to talk a little bit about suicide risk. I've been lucky enough to talk to CCC and other types of groups on this over the last year, and I'm happy to bring this to you folks today. So with suicide risk, I mean, obviously IBD is a debilitating condition. We know that. We know it affects a lot of people. And we know that the epi data suggests that suicidal behavior in this group is a fairly persistent concern. I've seen a lot of this on social media. I've connected with several patients on social media about their concerns about these types of things, from suicidal ideation to attempts. So I think in our population, we have to be monitoring not only how often these things happen, but I think, and that's the basic information, but what types of theoretical models might be engaging us from a mental health perspective, so we can look at, interventions. I mean, this is why we try to do this applied work, is to get to interventions. And also to start some momentum in tracking, suicidal ideation and suicidal experiences out to, the outcomes. So hopefully intervention and positive outcomes here. So I think this is really where this study came from. And, doing the link between these factors like, pain or disease status or anything around sort of the physical part of the patient's representation out to something like depression and suicidal ideation, that has been a mixed bag and really has not been informed by theory, as I mentioned earlier. So this is where we were going. So this study had two prime objectives. Number one was to get some prevalence estimates out there for suicidality. This doesn't mean suicide attempts. This is more about, it's an index of suicidal behavior, intention, ideation in particular. And the term is referred to as suicidality. Also to look at patient history, a little bit biomedical issues, and then again, put that theory-driven predictor into a model that helps us understand how patients might be at risk. Again, a model that helps us understand how maybe patients are at risk. It's an initiator of research. It's not the only answer out there. So here's our picture or our model. And this is basically a cross-sectional perspective. We have some of this data that's time seried. So that's going to be the next paper I'm working on, is what does this look like across time, and how does this model fall apart or stay supportable. I want to comment quickly on the prevalence rate here. And if we think about the number of people that were indicated as being at a level of suicide risk that was concerning on our measurement, almost 41% of this sample indicated clinically significant suicide risk compared with an adult general population. Now, there's other ways and other kind of norms that you can kind of throw that up against. And of course, the number will come down if we compare that with psychiatric inpatient unit, responders or something like that. But I mean, 41% is probably elevated in regards to tertiary care samples. At least some people suggest this, but I'm willing to say, look, we collected people wide and far and collected them from support groups and so on. So maybe some of this elevation, if this number is actually elevated at all, might be driven by the fact that people are seeking support. And, you know, you have a bunch of people who are the disease is fairly well controlled and aren't seeking this support, or aren't, you know, damaged as much by the psychological impact of disease ravaging your body. So there's some discussion about what that number is, but I'm telling you, when I got that number, I was completely alarmed. And I'm still alarmed every time I talk about it. It's way too large. Even if we reduce that by 15%, it's still way too big for my liking. So that's an alarm call. I think we need to be aware of that. Now on to the picture per se. You know, obviously we have IBD symptoms, and that's how we're classifying this, but it's a collaboration from measures put into this construct. This model was done in structural equation modeling. So that's the measurement model and the construct there. So we also talked about average body pain outside of those symptoms and shame. And we can see that there's significant relationships that exist between IBD symptoms driving these two up. And that would make sense because pain is a symptom we expect to see with IBD symptomatology. And what we did then is also brought in depressive symptoms, because we know that pain is in IBD is associated with greater depression. And we now know that shame, as other people have indicated, that's motivated from high symptomatology, also motivates a greater depressive symptomatology here. So what this does now is give us an opportunity to extend the model out. And this is where the suicide theoretical stuff comes into play here. So we know that hopelessness, a construct called psychache, and another construct called perceived burdensomeness, and I don't have a lot of time to go through a lot of that, so I'll try to give you the Coles Notes version of those factors. But we know that these three factors are essential reading in suicide ideation literature and suicide literature, period. So from these models that we dabbled on, we pulled them out, and we saw that depression obviously leads to greater hopelessness. It obviously pushes more psychache, and I'll define that in a second. And it also pushes fairly strongly this idea of perceived burdensomeness. So I'll start with this, you know, down here. I remember when I was first looking at this construct, I used to call this peanut butter, because I always get mixed up with that and thwarted belongingness and some other factors. But this perceived burden is pretty simple. It's like I perceive myself as a burden to people I love or care for. I am a burden. And that kind of, again, is triggered by a sense of hopelessness, and probably is a recursive relationship in here, although it's not modeled. So that perception of burden on others is really important to increasing suicide risk. And we know as well, this psychache, which is a factor that comes out of deeper depression and more hopelessness, is a factor described best as a psychological pain. And in the suicide risk literature, it's pretty predominant as a key factor engaged in patients when they become higher suicide risk, in other layers. So when we're thinking about that unescapable psychological pain that they just want to stop is a motivator for suicide risk and eventual suicide, so they say. So that's the model per se, and it tells a really interesting story, because I want to make a couple of points. All of these factors are important for me to look at when we think about IBD. Shame is something that my lab has gotten into over the last couple of years, because looking at social media, our patients keep telling us over and over again about how that's so important in their life. Looking at the current literature as well, other researchers have been pushing the button on shame and getting some of those expected relationships about how it's connected to depression, et cetera. So we understand that. Also, from just a pragmatic perspective, we modeled shame's impact on hopelessness through depression. That's one clear model, but I would believe that if we were to model shame directly into hopelessness or directly into perceived belongingness, that model might also show direct effects from shame into these factors. It might also be one of these factors that is recursive in model, like I suggested, where there are feedback patterns. So we don't have that modeled here. Obviously, it's a complicated model. We would probably need another 500 people to be able to do that. And our sample was not that large. We had enough to do the SEM, but we didn't have a very, very big sample. So this type of structural modeling, I would imagine, when we're looking at the data in the Imagine data set. I'm super pumped to see somebody kind of pull these types of models out with the variables that we've collected, because I think we've shown proof that this is a viable explanation for some of this deep talk. Now, we may not have these types of particular variables because they're theory-based and particular to my focus on extending this workout. But I just think having something like this is a real interesting story. It's not the only story in town, but it does put a story up for debate, and that's what research is, isn't it? Putting things up for debate. So I want to leave that model now and basically get to my takeaway points. Again, I can't emphasize that 40% is just unacceptable. Like, it's just, you know, it's just is completely unacceptable. And I would love to see someone come up with a suicidality risk index that was 5%, you know, but I don't know if I'd buy that. So I'm looking to see us do more work in this area and to see what we can do about it. When we think about other patient groups, the prevalence of suicidal ideation and fibromyalgia is around 30%, a little bit higher, just to give you some relevance to what my numbers might be in our study. Again, 8 to 34% in patients with lupus. So, I mean, I think there is a precedent in the existing literature that might suggest that our 40% is not out of whack, that this 40% might actually be tapping an important sample of people out there in the world. So I'm hoping to do more work in this area, but for now, I welcome debate on that number for sure. So when I think about what that study did for my brain, it really did emphasize an important theoretical linkage when it comes to suicide in IBD and the suicide literature, period. It suggests that there's no, the strength of the mediation, between psychache and perceived burdensomeness really is not different. So what that means is that both those factors from the suicide literature are important considerations in our group, because in other patient groups, that does not always happen that way. So what that means is you have more targets therapeutically that you could be looking at when you have patients in front of you with these types of concerns. So I think that's an important takeaway for sure from that work. Again, this is what I did earlier. I just threw this here. So when we're talking about psychache, it just gives you a little bit more background. You don't have to do a lot of work, reaching out. Interpersonal theory of suicide, again, and the constructs we looked at are included in here for your reading later. I just thought that would be useful, a little bit of extra useful stuff for you. So at this point, I want to talk about my wishes before I talk about measurement again. But my wishes are pretty simple, that, that these symptoms, these psychological symptoms and mechanisms for mental health that we've identified in this work, we know that they vary, and they vary widely. And I'd like to see that acknowledged. I think, I believe there's a lot of good psychological mental health work that's been done in Canada for a long time. Leslie Graff and Charles Bernstein have been pushing that agenda, and I appreciate that work. I think we need to see more of it, and I want to be part of that. So that's why we're doing what we're doing. My other wish is that cardinal psychological or psychosocial symptoms and those mechanisms we talked about, that those things that are impacting IBD life, I'd like to see those assessed more regularly. So that's another reason why I was pretty excited to be able to talk to you guys today. I appreciate it. And then thirdly, if we are acknowledging these and we're assessing them more often, what the heck are we doing about it? So I think that's the next thing. What does treatment look like? How do we manage that? And what type of assessments do we engage that can be useful in pushing that agenda? Because really, if you're doing psychological research and you don't have an applied focus about, well, what can this do to help my patients in the long term, knowledge translation into something viable, something that works for treatment, that informs where we should go for our patients, that's the only reason to do mental health work research, in my opinion. So this is what I really would like as my third wish. I mean, it is almost kind of the holiday season, so I'm going to say these would be my wishes for the holiday season going into the new year. So the last thing I want to just mention, I talked about the measures going through. I want to take a minute just to go through some of my measures, some of my favorite measures. The focus of this talk today would not allow a long exposure assessment of measures and different pockets. So I always say, go to what you like, go to your favorites and what you think is applicable to your group. And you can find that out by having conversations with people, reading some of the research. But I think conversations are so important. So I just want to talk about pain first and know, how do you assess pain? Now, there's a whole variety of ways to do it. You can use FACES scales. You can use all different types of things like that. But I would say if you're assessing pain in your patients, just make sure it's consistent, so that you can look at, the reliability of change or change and fluctuations due to your treatment. Because if you're trying, we talk about this a lot in narcotic prescription and use in chronic pain. And we think if you're not assessing pain often and you're providing treatment like opiate treatment, and how do you know anything that you're doing is working? So assessment of pain is really important. Obviously, we could get into discussions about face validity of some of the assessments, but I don't want to go there now. And I think this idea of assessing pain for me is simple. Ask, and I wrote it down here on the left, ask the patient, observe the patient, talk with the person, talk with their family, and make sure people understand that it may not be possible to remove pain. I think that's so important when it comes to patients that we see either IBD, pain specific, or other groups that I've managed over my career. Again, these are some, and these might be hard to see, these are some old school McGill snaps taken out of old textbooks and stuff. So when I talk about pain, I usually like to use the McGill pain questionnaire, and I'll tell you why in a second. But usually there's some kind of rating of the pain in a couple of different questions, and then some body mapping of the pain, which I think is so important. And then, what does your pain feel like? So characterizing the pain. Here's another example of that, where you can see, 20 different types of descriptors used, everything from emotional, mental, and physical descriptors. This is really valuable, and you'll see in a second. But I think that's really important to understand in regards to assessing pain. How are you doing it over time, and what is your patient saying about their pain? Again, short form, McGill on the other side, or a visual analog scale for pain, which is just basically a straight line. You can put a line over it and measure it. This is 10 centimeters long, so it works out to be, 100 millimeters. So you can find out a fine grain kind of measurement there. Has good ratio scale properties. You can use box scales. There's a whole bunch of different stuff, and obviously this is a short form of a McGill. I say obviously because it's written here, but that's something else that I use when I look at pain. The other thing that I really like to use is the body map, and this is our version of the body map. And I don't have it broken down, but I'm going to show you some of our data that we have a manuscript that we're working on right now that got rejected from the first journal, actually, because they said it was too psychological. I could not believe it. So our manuscript is getting sent off again to another place. But we look at pain like this, and it's really important because you can shade in an X up here, or you could shade in a big X right here, and then we want to know the number. So X marks the spot, but what's the pain rating out of 1 to 10? So we'll have some of these, you can imagine, very colorful with lots of X's in these patient profiles. This is what it looks in our IBD data set when we get that. And basically you can see these are the patterns or squares that we look at to try to look at pain. And in our data, just quickly, because I'm running out of time here, but in our data, we did a study, and I chose not to show this one. Maybe it was a bad choice, but we found that there's 3 basic types of pain groups from pain mapping in our IBD samples. We have an IBD pain only group that shows up with just pain in these highlighted areas. And that's the percentage of patients endorsing those areas. And then we have an IBD pain group plus 1 or 2 other pain areas that are associated. You can see not only do we have the buttocks involved, but we have low back involved. And we have some of the thighs involved as well, as you can see, and looks like some migraine pain as well. And then IBD pain plus 3. And this is the IBD pain areas, of course, that we identified as the predominant normal ones, but then we see these other types of pain throughout the body and fairly widespread. So just the importance of looking at that data, because this is what you see in clinic. These are tertiary care patients, and this is what we see. This is what the data we gathered in our clinic in Michael's and Michael Beck and Mark Ropoleski's clinic. So this is what we saw. This is what our patients told us, and that's important data as well. So I quickly want to just talk about catastrophizing. Here's what the measure looks like. And here really is the questions and the subscales under this. And one of the big findings from a lot of the catastrophizing literature is that patients who have a long engagement with their pain show helplessness. And you can imagine, you know, when I'm in pain, I feel like I can't go on. There's nothing I can do to reduce the intensity of it. It's terrible. It's never going to get any better. That is helplessness. And if you know anything about psychology and learn helplessness theory, you know, if you're feeling that way, you're not motivated to do much else except put your head down and just feel freaking miserable, because those thoughts are poison for giving you any type of motivation to move forward in your life. So I just wanted to highlight the catastrophizing stuff. And again, the anxiousness that shows up here through ruminative questions and points, magnifying the threat, and then sort of, like I say, the helplessness. So anxiousness and helplessness towards pain. That's how I refer to it usually, although this is the research-based construct title for that factor. So the last thing I just want to end off on is, can GI psychological experiences, and where do I get that help from? And I said, look, I just want to leave this for you again. If you don't know this stuff, I'm not going to go over it in any detail, except if you want to find a psychologist in Ontario, you can start here. I think that's a good place. And then there's a couple of other websites or resources that I think might be useful for you and your patients. So at that point, what I want to do is stop for Q&A. It's about 45 minutes, I think, or 40 minutes we have. So I hope that I didn't rush through things, but if you, obviously you have an opportunity to ask questions now. So Ada, it's all you now. Thank you very much.
Thank you, Dean, and for a wonderful presentation. I do have quite a few questions here to go through, so we'll see what we can get done. Some I feel like you might have answered after the question was written, but just for clarification, I'll read them out as they are. So first one, you mentioned there were 2 forms, and it was in one of your notes, to assess mental health and IBD. Are these considered the gold standard in mental health or recommended? Are there any caveats about these, or would you, are there others that you would recommend?
Well, let's back up. I think assessing mental health is a really interesting first question to start on, because what is mental health? I mean, that's a great question, right? Is it health-related quality of life? Is it depression? Is it anxiety? Is it obsessive compulsive personality traits? Is it shame? Is it coping responses? You know, so when I think about mental health or any one particular index of mental health, I have a hard time, you know, coming up with a particular answer for that. So I think whenever I talk about mental health and IBD from my perspective, what do you want to know about? Like, you know, because if you consider mental health just depression, then great. There's a lot of good depression measures out there that we could talk about. If you consider it, you know, health-related quality of life, there are some very good, you know, IBD health-related sort of quality of life questionnaires out there done by your own, right? You know, according even, yeah, I was just thinking about Charles Bernstein's measure, and if Charles on the call, he can jump in and tell us a little bit about his great measure. We've used that. But there's a variety of different measures that are out there. So what is the mental health aspect you're focusing on? That would be my other question. If you're looking for a general mental health scale, I don't really have one that would be a favorite. I think there are a bunch that exist. My strategy, if I had to pick one, I would go out and I would do a lit review. I would look at how people are using that measure or those types of measures. I would look at the method section of that paper. I would look at how they describe the measure. I would go get the measure, and then I would mentate on whether or not that measure fits what I want to get done. Because what my perspective has always been in teaching science and conducting science is, what is your particular question? And if it is about general mental health, then you can find a measure for that. But I tend to be more specific. So for me, today you saw health-related quality of life, and you saw suicidality risk, right, as big movers in our data, and a variety of outcomes looking at mental health in regards to group therapy. So there'd be some primary, which could be health-related quality of life, but secondary measurements as well, which would be shame and catastrophizing, like I talked about. So when we think about mental health, I don't think I answered maybe that question the way someone was posing it, but I don't think I can. I think it's about, I want to describe the process of defining what your dependent variable is. I think that's most important, because the measurement can come after. And then you reconcile what you think you want with what the literature has and what measurement is out there. And I think you'll find your answer. I hope that helps.
Thank you. Another question here. Have you looked at potential connections between socioeconomic class or ethnicity and GI-related mental health issues?
No. No, not yet. I mean, we do have a question that kind of looks into, we do have ethnicity data. I am very interested in doing more. I was particularly interested in indigenous health over the last couple of years, being engaged with some of that work with my students. And again, thinking about, populations in Canada that deserve a focus. I think indigenous health would be high on my priority list. Yes, we have BIPOC concerns, and I think that we should be thinking widely in regards to diversity in our sampling. That's another big thing we've been thinking a lot about lately here at Queen's, and in my lab in particular. We have a weekly discussion about how to kind of increase diversity in sampling, but also, the process involved with that. So from a cultural perspective, there is IBD research that's international. There is cultural research out there, but because we did not collect our data with a particular focus on ethnicity or, some of the diversity issues, again, if we did not, we don't have an established relationship with an indigenous community to be able to kind of build that partnership. And that's something we're actually working towards in my lab now. But that takes a little bit of time, and we respect that process. So no, we don't particularly focus on that. And that, in my opinion, is a shortcoming of some of our work. So we're looking to expand and be better at that in the future. And I'm all ears too. If you guys have ideas out there or things that you think that Tripp should hear, please email me. We are in, data gathering mode on that, and process, for the process, our ears are wide open on what could be done there. But I know there is international work on IBD, and I think that could be a bit of a proxy to get an understanding of how ethnicity or culture might be influencing some of the outcomes, as long as the measurement is similar across studies. That's the only proviso. If you've got two completely different measures of depression, and they're not even asking about the same thing, and one is heavily influenced by somatic symptoms and one is really cognitive, it would be unfair to compare those in a condition like IBD across cultures in particular. That's a great question. I think something we should all be thinking about.
Thanks. So here's another question, maybe if your lab hasn't done, but are you aware of any work looking at the microbiome and suicidality?
Oh boy. Yeah, you're taking my next CCC grant right out of my pocket here on this one. I would love to see more of that done. I am unaware at the moment, and I obviously would love to be corrected, because I'd love to know of any work that's being done that comes completely to my mind. I know there's real good work on the microbiome and depression, anxiety, even some work starting to teeter into personality factors. When we talk about the gut being really thrown off. So I think there's some really cool work that's edging that way. I haven't seen anything particular that talks about suicide risk or suicidality, but I'm sure there's something there. My focus was more on the psychosocial factors, obviously not being able to sample, bio and biomarkers in our online study I can't get to that. So that wasn't a focus of ours, but I am completely hoping that that stuff is happening in big numbers soon. Yeah. So it's the answer. Quick answer is no.
And you did mention a little bit around comparing the suicidality risk in IBD to other chronic diseases.
Yeah.
Are there any IBD biological variables, such as inflammatory markers, that might be associated with suicidality?
I would think yes. I mean, obviously we didn't collect that data in our sample. Like I said, it's an online study, but I would think clearly there would be. If you think about depression as the proxy for suicidal ideation, depression at its higher levels, if you're talking about more severe depression, suicidal ideation is very common. So and we're not talking about someone who's checked into hospital suicide risk on red. That's different. But if we think about the data that exists now, if you look at the microbiome data looking at heavy depression, that would be a good indicator of what would probably be showing up in people who are, actively suicidal, actively in a sense that you're beyond just the random ideation of it, but that you have thought out a plan, that you're more of a risk than someone who has that passing or fleeting thought of like, I'd be better off dead, which is a really common thought actually in depression. And I think a lot of people aren't aware of that. So I think that would be the best proxy for my mind, but it definitely is there. It has to be there. But again, I can't point to a particular study, but I'm going to look after we get off the call, because now you got me really thinking about that. It's got to be there. I mean, again, if it's not directly identified, the proxy of severe depression is close enough for me to say, what's the microbiome saying there? I think that would be a great place to start looking for an answer.
So another question here. So you have a number of psychological endpoints in some of your studies. How do you deal with the problem of multiple testing issue?
Well, I'd probably need to know a little bit more what they mean by multiple testing issue. I'm not sure what that means. If you mean overlap in constructs, which, like happens in some psych research. So for example, if you have a bunch of dependent variables or a bunch of variables, whether we want to call them independent or dependent, that are similar in nature. I'll give you an example. When we were looking at a lot of our work with, catastrophizing and that sort of anxiousness and helplessness, there's quite a bit of literature that was concerned that the catastrophizing construct was basically redundant with measures of depression. So they're both, because catastrophizing is a process very clearly, before it got linked to pain, is one of the primary cognitive processes that are involved with the development and maintenance of depression. So there was a lot of discussion about, these constructs are overlapping and therefore redundant, and that creates issues with measurement. Because obviously, if you have a bunch of measures that are kind of measuring the same thing, then you're going to have not only diluted results that might be confusing, but just basically flat results or nil endpoints that it's soaking up so much variance in the equations that it just doesn't make sense. So if that's what you meant by the measurement issues, I can say that if we look at the case, using one case would be catastrophizing and pain, catastrophizing and depression. The literature that's looked at that's pretty clear that although there is a correlation, there's definitely an association. If you think of a Venn diagram, they overlap, but they're not like that. Like, I mean, that's when I get really worried, when a correlation between two of my variables are at like 0.75. 0.7 is a mild alarm. I don't get too worried about that. But 0.75 for a zero order correlation, or 0.8, I start to go, ooh, that's redundant. So then I start thinking about combining factors or losing variables, just because from a statistical perspective and a theoretical perspective, it gets pretty muddy. So I hope that's kind of where the question was kind of aiming, but I think that's the best way I could answer it.
Okay. Thank you. And so I think we might just have one final question here. We'll see how long it takes you to answer it, Dean. But when you're conducting research in this area, do you need to put in place any supports if respondents indicate that they're in a poor state of mental health? What is the best practice for these types of studies?
That is a fantastic question. And one of the hats that I wear when I'm not on these calls and having fun with you guys is the General Research and Ethics Board chair at Queen's. Not that ethics isn't fun, but yeah, ethics isn't fun. But no, I'm joking. Ethics is actually super fun. That's the nerd in me for sure. But this question is very, very important because I review studies all the time, and our board reviews studies all the time about suicide, about mental health issues, about, all types of issues like that. And at a bare minimum, when you're inquiring about depression or you're inquiring, again, you're inquiring about when you use measurement, like let's say the Beck Depression Inventory, or even a PROMIS measure, or whatever you're using, the HADS, whatever your favorite depression measure is, PHQ-9, I tend to like for research. But when you're using that measurement, it's not a diagnosis of depression. That's one thing you want to clarify. You're not diagnosing a patient with depression. You're saying they have symptoms that are elevated that mimic a depressive category. It's not a diagnosis. You need to do a clinical interview with that to basically be better, or a SCID or something like that. So when we're thinking about that, at the minimum, when you're seeing elevations in depression, let's say, what we want to see is resources, at least minimum resources for the patient. And if they say that they're in any type of distress in your survey, because some surveys are anonymous. So how do you contact the patient back? You can't. So if they do have elevated scores and depression scores in our surveys and other surveys that come through Queen's, you have to provide not a debriefing form, but a form of resources for that patient. So that would be emergency online stuff that you can get in Ontario, let's say, if we're doing research around Queen's or with Queen's students. If we're using students, it would be mental health resources on campus. It would be advice to talk to someone that you love or someone who cares for you, see your GP about these concerns, because we don't, if the study's anonymous, we don't feed back data to them. So they're going to fill out these questions. They might be upset by that. So that's an important thing. That's like a bare minimum needs to be in there. If now you're looking at doing particular suicide research, and this is going to be the extreme of this, and you're asking, you have an experimental design that you take actively suicidal patients in and you get them to go through some exposure of looking at, let's say scenes that would mimic a suicide, a post-suicide scene. And I've seen this research. Then you have a very heavy clinical duty to be on that. So there's a psychologist that will, because the patients get feedback, we know who the patients are. And if they're scoring at anything, or if there's any type of risk, post-experiment, then the psychologist sees and interviews those patients immediately. So that's like, we're talking within a 4-hour window of somebody doing this sort of extensive work on suicide research, that they're contacted by the psychologist supervising that. They're also pre-contacted by the research assistants who are trained to kind of recognize the scores and then put that up the chain. They're given resources there again. And if the patient on debrief says that they feel actively suicidal and they have a plan, then you hit the red button and then the psychologist is here immediately, and the patient might be walked over to the clinic for potential admission. So depending on what you're doing, there is a minimum and then there is a maximum that we require from an ethics perspective, from a human perspective. And I think that's an important scale. So wherever you fit in there, you'd have to scale that up. That would be my best advice.
Well, thank you very much, Dean. You've done an incredible presentation, very informative, and we really appreciate all your references, and we will post that up on our website so people can refer back to that. So that's very helpful. So thank you so much for your time. Thank you to all of Imagine's partners and sponsors that make these presentations available, and wishing everybody happy holidays, keep safe, and we'll see you again in January for our next webinar series. Take care.